I'm very happy to have an opportunity to be here. I've been studying the relationship between welfare states and human health for many years, and it's a pleasure to be able to see what other people are doing, and also to hopefully get some reactions, some comments from other people on the approach that I've been following. I don't know that I'm going to be offering much guidance on successful strategies. My approach is more an attempt to understand what's been happening over the last half-century in welfare states and in their impact on patterns of population health status. So without any more ado, I'll begin. And I want to begin with the question that has been in front of me as I've explored this area, and it's: what is the most effective mode of social organization for promoting population health and, by implication, reducing health inequalities? I'm assuming that the two questions produce the same answer, although sometimes successful strategies, actually, as we discovered yesterday, not discovered, or were reminded yesterday, sometimes successful strategies actually increase health inequalities, as is the case with the reduction in smoking. The successful public health campaign, to the extent it did in fact produce reduction in smoking, a class stratified reduction in smoking, did of course have the effect of increasing health inequalities. So the question, to return to this slide: can variations in the epidemiological history of welfare state regimes answer this question? And I just want to issue a cautionary note. Assuming that there is an affirmative answer to this question, we mustn't assume it would be easy to transfer successful policy interventions from one socio-historical context to another. Policy implies purposeful public intervention designed to achieve defined goals, while the welfare state regime implies a whole repertoire of interlinked social institutions which have evolved over decades, even centuries, shaped in the course of their development by democratic class struggle, punctuated by major historical events like world wars, economic crises, and the cultural antecedents and upheavals that form the background to these events, so that a successful policy in one welfare state regime may not be portable to another whose ethos is entirely different. We may conclude that policy depends on political will, and to paraphrase one famous German social theorist, men make their own policy, but they don't do it under conditions of their own choosing. Why should we expect the welfare state regime concept to offer the best approach to uncovering the secret of a healthy society? Well, I think there are good reasons why we should expect this to be the case. Welfare state regimes are alternative modes of societal modernization. They developed in the 20th century primarily to insulate population livelihood from the risks of market capitalism. Esping-Anderson introduced the concept of decommodification to capture variations in the capacity of welfare state regimes to perform this function. This concept, decommodification, involves the removal of commodity status, that's something to be bought and sold, to remove this status from essential human needs on the grounds that these goods and services should not be subject to market exchange and profit. Sorry, there's a mistake there. I left out not. Should not be subject From all that we know of the relationship between material inequalities and health over the life course, it makes sense to predict that decommodification will be a very important variable differentiating health outcomes between welfare states. However, as Esping-Anderson's feminist critics were quick to point out, commodification is not necessarily bad, at least from their point of view. It can entail liberation from dependency relations, and as far as women are concerned, the commodification of their labour is to be welcomed and not resisted. So in face of this feminist challenge to his perspective, Esping-Anderson added an additional concept to his model of 3 welfare state regimes. He added a fourth regime, an additional concept and a fourth regime. The additional concept is defamilization, and it measures a welfare state regime's capacity to liberate individuals from dependency on the most traditional of all welfare institutions, the family. In the same context, he also added a fourth ideal type to his model, the familist welfare regime associated with the Mediterranean region and to some extent also found in Japan. If we apply both concepts, decommodification and defamilization, his original conclusion, this is Esping-Anderson's original conclusion, is unchanged. The social democratic regime still emerges as the most successful mode of organizing social life to protect human well-being, with the added benefit in this context of strengthening the immemorial ultimate purpose of social organization, the maintenance of the flow of population through the social fabric. Esping-Anderson reaches this conclusion by observing rates of fertility in different welfare state regimes and noting, as many of you are obviously aware, that the more familist welfare state regimes record the lowest rates of fertility. Ironically, they valorize the family, but their fertility rates are very low. The defamilization concept is, however, an interesting tool from the perspective of social epidemiology, and we haven't talked about it yet in this conference, or at least not in the sessions that I've been in, because social support, typically associated with family life, is known to exert a very powerful influence on survival. We don't include it normally as one of the dimensions of health inequality, but marital status, for example, continues to exert amongst the most powerful effects on survival. And that's been a statistical correlation observed for more than a century, not only by Durkheim in his famous study of suicide at the turn of the century, but 50 years previously by the English medical statistician William Farr in some research he did on French statistics in the mid-19th century. So family life has traditionally played an important part, a very important part, delivering welfare, protecting the well-being of ordinary people. So those are my preliminary remarks. Now what I want to do is to examine the health output of 5 welfare state regimes. I'm going to measure, my measurement of health is the risk of premature death, and I'm using potential years of life lost between the ages of 1 and 75. This is based on the assumption that under modern conditions, it's relatively, the conditions of the second half of the 20th century, living a life of at least 7 decades is something that most individuals could expect and could look forward to. The nations included in my study include Britannia, which I label the old world liberal welfare state, and it includes England and Wales, Scotland and Northern Ireland. A new world liberal version, the United States, which is quite different in many ways from the old world liberal version. A corporate model, a corporate type, which includes, in my study, Austria, Belgium, France, and the Netherlands, and then a social democratic version, Denmark, Norway, and Sweden, and then finally the Mediterranean version, which includes Greece, Italy, and Spain. The time period that I'm looking at is 1960 to 2000, and I want to draw your attention in what I'm doing to two different types of gender inequality, because one of the things that interests me here is the relationship between gender and health in different welfare state regimes. That will become clear in a moment. But what I'm doing is comparing women and women in different welfare states and men in different welfare states. So instead of measuring gender inequality by contrasting male and female experience in a single society, I'm examining gender inequality by looking at the social situation of women, comparing them in different societies or in different types of society, different welfare state regimes. So here's a chart that depicts the trend in premature death for these 5 welfare state regimes. And this is for females. The trends run from 1960 to 2000, and there are some quite striking consistencies, but also some changes over time. First, we may notice that the two liberal versions of the welfare state maintain the most negative trajectory throughout the period. The New World Liberal and the Old World Liberal record the highest rates of premature death in 1960. That's still happening in the year 2000. There's been some divergence between the United States and the UK, or Britannia as I call it, in that period. In the latter part of the period. But one of the most striking and surprising features of the chart is the very progressive trajectory charted by the Mediterranean regime for women, for females. It appears from these data that the answer to the question, which is the healthiest form of society in terms of welfare state regimes, produces an answer we wouldn't necessarily expect. We might have expected the answer to be the most female-friendly form of society, which is social democracy. But in this case, we can see that social democracy begins the time series with the most propitious situation. Indeed, there's considerable inequality in 1960 between females in the social democratic welfare system and in the others. But by the end of the period, you can see that the social democratic combination has moved above the European average, has deteriorated, while the corporate and the Mediterranean regimes either lie upon the European average or below it. What happens with males? Well, there are some interesting differences here, and there are also some interesting observations in this chart. First of all, the matter of consistency. We can see that the New World liberal welfare state continues to, as with the female pattern, to reveal the most consistent pattern of disadvantage. But in this chart, we can see that the social democratic welfare state begins and ends the series showing the most advantaged pattern, which might produce the inference that social democracy does more for males than it does for females. Okay, there are factors to be looked at in this, but another thing I want to draw your attention to here, which is important, is that in 1960, or 1963 is the measurement point here, the male mortality in the social democratic regime had already achieved the level not reached till after 1980 by males in other societies. Okay? Now what this means is that, and it's to some extent, it was also true of the female data that we just looked at, although not to the same degree. What this means is that before what Esping Anderson calls the golden age of the welfare state, when the more, what can we say, more avant-garde policies of decommodification and defamiliation were introduced, social democratic males were already enjoying very high health status. And it does probably cast some doubt on the singular importance of social democracy, or the institutions of social democracy, for male mortality. That certainly is, it looks like before, or at the very origins of the Swedish, Danish and Norwegian welfare systems, they were already operating with very high standards of health. Okay, so that, and indeed, if we were to express these data in a histogram with, I didn't bring it with me, but if we were to do that, we would see that the rate of improvement in health in this period was actually shallowest for social democracy. And of course it happens because of the very high standards, to some degree, that had been achieved at the very beginning. There is another interesting element to this chart that I want to draw your attention to, and that is the situation of Britannia. Britannia, the old world liberal system, begins the time series with the second worst rate of premature death. Originally, I didn't add the New World Liberal, and so it was very clear that Britannia was the worst at the outset. But you can see that over the period of this study, Britannia charts a very progressive trend for males. So that a welfare state system in the UK that appears to be not very good for females, remember the sustained excess of premature death among British women, we find a different pattern among British males. Now, what some of these data suggest is that one man's welfare state, one man's healthy society is not necessarily the same as one woman's healthy society, and that the answer to the question, what is a healthy society, may vary by gender, that gender inequalities may be an important factor that needs to be carefully considered. I want to draw your attention to a couple of features of the study that I've been doing, which I'm not going to dwell on very much, but I want to show you some interesting divergences between welfare states that I believe are worth considering. And these relate to what I call types of mortality in welfare state regimes. In what I've been doing, I've distinguished between early and late premature death. That is to say, potential years of life lost before and after age 55. As life expectancies increased in the 20th century, we've come to see premature death as something that happens that everybody lives to something like 60 years or 65 years, and then there's inequalities in the length of retirement. But in fact, there is still quite a lot of premature death that occurs before the age of 55. And so what I've looked at here is the relative success of different welfare state regimes, or different nations making them up, in terms of preventing very early premature death, and then their success in prolonging the length of life after the age of 55. Another important distinction to be made is between external causes and universal causes. That is to say, the relative significance of accidents, suicide, and violence versus the diseases of aging. And I just want to show you some of the variations between welfare states for these two types of mortality. First of all, early premature death. This chart gives you the distribution of these two, the proportion, the contribution of early premature death in percentage terms to life expectancy between the ages of 1 and 75, this is actually. And this is for the year 2000. And you may note that Britannia, the British welfare state, actually appears to be most successful in preventing early premature death. The least successful is the United States, followed by the corporate regime, which is a bit of a rag-bag of nations, to be honest. It's the most heterogeneous and maybe the least convincing combination of nations making up the corporate regime. In my study, indeed, I've considered not particularly using that regime type because of the sheer variation between the nations that are contained within it. Here's type 1 mortality, that same chart I showed you earlier, for males over the period. Type 1 mortality is external, what is known as external causes, accidents, violence, and suicide. And what we see here, you can now understand why the UK was so effective in preventing premature death. You can see how very low are the rates of type 1 mortality in Britain. That's a big difference between the New World welfare state and the Old World welfare state. Okay. In fact, the two liberal welfare states here are at different ends of the spectrum, and it's consistent over the entire period. I'm quite interested in the consistency of these trends over time, because that really does suggest that it is something in the institutional infrastructure of these societies that is propelling these trends. You can see that within Europe, it's the corporate welfare regime that records the highest rates of type 1 mortality. And here's the rates for females. And it's, to some extent, the rates are much lower among females. The differences are less, at least the differences over time are less extreme. You can see that the rates of decline are much shallower in females. That's partly because there was less type 1 mortality in the early period compared to males. And here you can also observe that the rate is very low among females in the Mediterranean regime, as it is in Britain. Rates of type 1 mortality among females are very much affected by the rates among males. Many of them, of course, many of these deaths occur, the deaths arising from this type occur in motor vehicle accidents and the like, and sometimes that involves males and females together. This is type 2 mortality. These are the aging diseases. And here we see, once again, that progressive trend of the UK, starting from the highest rates of premature death from type 2 mortality, universal causes, these are the diseases of aging, and you can see the same pattern among social democratic males. And indeed what we see here is something of a north-south division, although it's not particularly, it would be easier if we stopped the comparison in 1993, because by the year 2000, the Mediterranean regime has in fact converged on Britannia. But it's the corporate regime and the New World liberal regime which record the highest rates of premature type 2 mortality in 2000. And here is type 2 deaths. These are let me emphasize once again, these are the medical causes, and what we see here is the same dominant pattern. Of course, the female rates of type 2 mortality are much closer to all causes, and so this is pretty much a reproduction of the first chart for females that I showed you. So let me summarize the substantive findings from these charts. Firstly, we should acknowledge that the risks of premature death declined substantially in all welfare state regimes between 1960 and the year 2000. This was a progressive period in epidemiological terms for all these societies. And if we contrast it with what was happening in Eastern Europe at the same time, we can see that industrial market capitalist societies, welfare state systems in Western Europe and elsewhere in the world had a more successful period of improving population health status than the alternative collectivist mode of societal modernization that was attempted in Eastern Europe. And indeed, if we look at the trends in Eastern Europe, although there was a crisis of mortality at the collapse of the system and at the end of the 1980s and early 1990s, there was a very poor performance in terms of population health status in the decades leading up to this as well. So industrial capitalism in its various welfare state forms of clothing has a pretty progressive record during this period. The social democratic regime overall charted the shallowest decline, but this regime had a massive head start in 1960. Gender is a major factor of differentiation. One man's healthy society is not necessarily one woman's healthy society, and vice versa. And we can contrast this with the male and female trend of Britannia. Among males, the social democratic system charts the most progressive course, but Britannia also charts a progressive trajectory, somewhat surprising in some ways. For females, the feminist Mediterranean regime is the surprising success story, charting low rates of type 1 mortality and the most progressive decline of type 2 mortality over the period as a whole. The feminist regime does not enjoy a reputation as a female-friendly society, yet it emerges as the most propitious epidemiological environment for women in this period. Denmark, so what I want to do now is to say a little bit about Denmark, because Denmark plays an important part in what I call the sluggish performance of social democracy in the period that I'm looking at. Denmark makes a significant negative contribution to the sluggish performance of social democracy in the second half of the 20th century. In 1960, Denmark recorded rates of premature death below the European average, but above the social democratic norm. The gap between Denmark and other representatives of this regime type widened each decade, and by 2000, Denmark displayed the highest relative risk of any nation. Denmark poses a problem for those of us who wish to argue that the social democratic regime is the healthiest mode of organizing society. Here's the female data for the different welfare state regimes, including Denmark, in 1963. This time, what I'm doing with this chart is depicting the excess or the deficit of premature death over the course of the lifetime. The green chart is the Mediterranean, the green line is the Mediterranean, the red is Britannia, the deep blue is the social democratic, the blue is the corporate continental, and the broken line is Denmark. So you can see that Denmark is not so well placed as social democracy as a whole, but it's below the European norm in 1960. At most points of the lifetime, only at age 35, is there some excess mortality. 40 years later, here's the pattern. Sorry, the fourth measurement point for me, 1993. What do we see? Well, first of all, there's been a convergence in the early part of the lifetime. Most of the extent of excess or deficit in up to about age, I've managed to obliterate the age. The age is at the bottom there, but you'll have to imagine them. Up to about age 40, there's been a convergence, but there's much divergence after this age band. And what we see is if I didn't have Denmark separately identified here, what we see in 1993 is a pattern of female disadvantage in the northern welfare regimes, including the social democracy and the liberal regime in Britannia, and more advantaged health status in these older age bands in the corporate and the Mediterranean. But you can see how much Denmark influences the trend of social democracy. There's a huge excess of mortality there in Denmark. This gives you the Danish data for a number of separate causes: circulatory disease, lung cancer, breast cancer, and cirrhosis. And in each case, I'm looking here at the trend over the course of the lifetime. That's more of what you might call a life course approach. And you can see that there is a big divergence between Denmark and her fellow representatives of the social democratic regime type. And it's found for all these causes. Note the exceptional excess for cirrhosis and lung cancer. Sorry, I think I've got a feeling I want to do this.
Maybe to stop now.
I should stop now. Okay. Okay. Shall I stop now, or do you want me to do? Okay. Well, let me just explain what, without these slides, quickly why I think Denmark is deviant. I think to understand Denmark's deviance, we can't just look at the data for the last 20 years. I think we have to understand Danish history and Danish culture, and we have to look at how that contributes to the specific characteristics of the Danish version of social democracy. the historical legacy that distinguishes Denmark from the rest of social democracy is that Denmark was never a temperance nation. Sweden was, Norway was, and in each of those cases, the social democratic parties in these two nations were also temperance parties. And their mission was not merely to create a welfare state, but to civilize the working class and to change patterns of male drinking behavior in particular. And I think that this is a very important factor running through the development of the welfare state, the social democratic welfare state. The early version of the welfare state was known as the friendly societies, and these existed all over Europe. They existed in Britain, and these were collective organizations where members got together in order to provide, to ensure against socio-economic misfortune. And these friendly societies had to seriously discipline their members in order to protect their insurance funds. Okay? And the social democratic welfare state system grew up, in a sense, on this kind of principle, as did most welfare state regimes. But the social democrats took the issue, the problem of disciplining the members, disciplining the citizens very seriously. And I think there are very significant differences between Swedish and Norwegian social democracy and Danish democracy in this respect. And I think the effect of that today is witnessed in much higher rates of drinking and smoking in Denmark as compared to the other regime type representatives of this regime. Thank you.